Okay, so it's 1 minute past 5, so very warm welcome to our virtual grand rounds in radiation oncology. You know our program. We aim to provide the latest science presented by our top speakers in a very interactive format. As always, it's the first Wednesday of the month. So despite we were just returning back from the Astro meeting, we're all still a bit tired, at least the radiation oncologists. We have another highlight prepared for you. Again, many thanks to our societies which are endorsing and supporting us, the ASTRO, SASTRO, and the German Society for Radiation Oncology. And as always, if you might have missed one of the prior webinars, they are all being recorded, they are all being available on YouTube, and they are all available for free. So please go to our homepage and have a second look. Today we speak about esophageal carcinoma. We know which is a very dynamic field. We saw potentially practice-changing trials where we saw results which we didn't expect so much. The ESOPEC trial, which compared neoadjuvant chemo versus neoadjuvant radiochemo, FLOT versus the cross regimen, which reported an overall survival benefit for the FLOT scheme. It was surprising in a way because the compliance to the radiation oncology treatment and also the PCR rate was slightly lower than expected. And now we're having another option, which is super fascinating. We know that quite some of the morbidity is coming from the surgical procedure. So how do we handle patients which are achieving a clinical complete response and then are being offered an organ preservation strategy? We are doing that for decades in anal carcinoma. This is becoming a standard of care in rectal carcinoma. And now we have important data from the SANO trial. I'm very happy and honored that Berend van der Wiel will present the trial. He has been developing this protocol during his PhD and now has finished his PhD, is in residency program for surgery, and has been presenting the primary endpoint of this analysis published in March 2025 in Lancet Oncology. So huge congratulations. Many thanks, Berend, for joining, and we're looking forward to the presentation and the questions thereafter. I guess there's going to be many questions, so please go to the chat and you put your questions in the chat. With that, Berend, the floor is yours.
Perfect. Thank you, Matthias, for the kind introduction. I will share my screen in the meantime. I think you should see the presentation right now. Matthias, is that all right?
Perfect.
Perfect. Thank you. So I have the honor to present to you the results of the SANO trial, where we compare neoadjuvant chemo radiotherapy followed by surgery versus active surveillance for patients with locally advanced esophageal cancer. I do not have any conflicts of interest. Well, let's start with the beginning. In 2012, we published the cross trial with the Rotterdam group here in the Netherlands. And perhaps you all know, but there we compared neoadjuvant chemo radiotherapy plus surgery versus surgery alone. And actually quite recently we published 10 years overall survival results, and we concluded that addition of neoadjuvant chemo radiotherapy to surgery resulted in a overall survival benefit for patients. And since then, actually, neoadjuvant chemo radiotherapy is standard treatment for these patients in large parts of the Western world. What we saw is that nearly 1 out of 3 patients achieved a pathologically complete response, which imposed us with a dilemma whether all patients need a standard resection after neoadjuvant chemo radiotherapy, or should we be willing to implement an active surveillance strategy after a clinically complete response, as determined with diagnostics that we use in response evaluations. So active surveillance is the concept where we perform frequent clinical response evaluations using diagnostics, and we perform surgery only after proven residual tumor without the presence of distant metastasis. Potential benefits are an improved quality of life for patients who do not need to undergo major surgery, which results often in morbidity and sometimes even in mortality after esophagectomy, and perhaps less post-operative complications and mortality in total for those patients undergoing active surveillance. Potential pitfalls do also exist, of course. So potential pitfalls are that it could result in development of irresectable regrowth if we can't detect the residual tumors well enough, which could also result in an increased frequency of distant dissemination and distant metastasis, all jeopardizing overall survival. And therefore, we don't know whether overall survival after active surveillance is comparable to that of patients undergoing standard surgery. Therefore, we aimed to compare the efficacy of neoadjuvant chemoradiotherapy followed by active surveillance versus standard surgery for patients with locally advanced esophageal cancer. And therefore, we performed, or we did the SANO trial. The SANO trial is a phase 3 stat-wedge cluster randomized trial with a non-inferiority design. We include patients with locally advanced esophageal cancer undergoing neoadjuvant chemoradiotherapy according to the cross regimen. You all know this consists of 41.4 gray radiotherapy. And if patients have a clinically complete response, which means that after 12 weeks after completion of neoadjuvant chemoradiotherapy, and after 2 response evaluations, no residual tumor is detected, patients are randomized according to that stepwise cluster randomization between active surveillance or standard surgery. And those are the patients that are included in the trial. We analyzed overall survival with mixed effects Cox models, and we analyzed according to a modified intention to treat analysis, which means that one crossover moment was allowed at the second response evaluation. So that was one crossover moment 12 weeks after neoadjuvant chemoradiotherapy was completed. So that means that patients who had a clinically complete response at 12 weeks and were randomized for surgery, but would rather undergo active surveillance, were able to cross over, and vice versa as well, of course. The primary endpoint of the study was overall survival. And as I told you earlier, we have a non-inferiority design, which we defined as less than 15% differences in overall survival at 2 years. We have a lot of secondary endpoints, of which those are amongst disease-free survival, operative and pathological outcomes, post-operative complications, the distant dissemination rate, so the frequency of distant metastases, and of course the health-related quality of life of patients. If we go through with the results, then this is the table 1 of the study, so the baseline characteristics. I didn't write it all out, but I think you can believe that the population was quite a typical population of patients with esophageal cancer. We included 198 patients in the active surveillance group and 111 patients in the standard surgery group. Median age was 69 versus 68. More than 3/4 of the patients were male, and among 3/4 had an adenocarcinoma. 2/3 had a WHO classification of 0, so they were quite in good condition. Then you see the primary endpoint actually of the study. We see the Kaplan-Meier curve of the overall survival, with on the x-axis the follow-up in time in months, and on the y-axis you see the survival. And the blue line represents the patients undergoing standard surgery, and the red line represents the patients undergoing active surveillance. And if we then first look at the non-inferiority, which was the main outcome, at 2 years, we see that patients undergoing active surveillance had a 2-year overall survival of 74% versus an overall survival of 71% for patients undergoing standard surgery. The 95% boundary is that it was 7% worse for active surveillance, which means that this was below the non-inferiority margin of 15% worse. And so we could conclude within these data that the active surveillance was non-inferior to standard surgery actually on 2 years, or at 2 years. Of course, we also looked at the entire follow-up and performed Cox analysis, and there we see that with a hazard rate of 1.14 for active surveillance, the overall survival was not statistically significantly different between both groups if we take the whole follow-up into account. Afterwards, we looked at the disease-free survival. Again, actually the same kind of illustration. On the x-axis, the follow-up, y-axis is the survival. Blue are patients undergoing surgery, and red are patients undergoing active surveillance. And also on this point, we see that there was no statistically significant difference between both groups concerning disease-free survival, with a hazard rate of 1.25 for patients undergoing active surveillance. Then we checked on 2 points within 16 months and at 30 months, all patients eligible underwent a PET-CT scan, and we saw that patients undergoing standard surgery had a distant metastasis in 34% of the cases versus 43% for patients undergoing active surveillance. So it was numerically higher for patients undergoing active surveillance. But again, this did not meet statistical significance with an odds ratio of 1.45. A lot of patients had to undergo postponed surgery for local regional recurrences within the active surveillance group. So in total, 83 patients underwent esophagectomy while initially undergoing active surveillance, and they all underwent esophagectomy because of local regional recurrences in the esophagus. So logically, the time to surgery was longer for patients undergoing active surveillance with a median time of 6 months. But we see that the other aspects of the operation, so the radicality rate of the resection, the number of lymph nodes resection, and also the operating time between both groups were really comparable. And also the rate of post-operative complications was comparable between both groups. It's again, it's kind of shocking how high the complication rate is after esophagectomy. More than 80% of patients have at least one complication after esophagectomy, but there was no difference between both groups. So this indicates that waiting longer for an esophagectomy does not result in higher post-operative complications or less radicality after an operation. So if we take a further look at the clinically complete responders who underwent active surveillance. So in total, of all the 309 inclusions, we did both standard surgery and active surveillance. This was a group of patients with a clinically complete response. And in total, we included 776 patients. So 34% of the patients had a clinically complete response in the end, so roughly 1/3. And of those patients in the active surveillance arm, 17% developed distant metastasis without undergoing esophagectomy. 96 patients developed a local regional regrowth, of whom I just told you 83 underwent an esophagectomy. And 69 patients still have a persistent clinically complete response. So that's also roughly 1/3 of the patients still have a clinically complete response. And then we try to determine how many patients did benefit from an active surveillance strategy and how many patients avoided an unbeneficial esophagectomy. So this is kind of arbitrary because we believe that you see that I write it down over there. 22 patients developed distant metastasis within 6 months after completion of neoadjuvant chemoradiotherapy. And I like to say that those patients did not undergo esophagectomy. So we believe that the 22 patients who developed quite early in the process a distant metastasis, that they benefited from active surveillance, because we believe those were distant metastases that were already present subclinically at diagnosis, but could not be detected then with PET-CTs that we performed. Furthermore, the 69 patients who still have a persistent CCR also benefit from an active surveillance strategy, we believe, and therefore we believe that in total 91 patients have been spared an unbeneficial esophagectomy, which is nearly half of the patients included in our trial for the active surveillance group. Lastly, we also looked at the short-term health-related global quality of life, where we see, and I'd like to emphasize that In the blue, we see the patients undergoing standard surgery, and in the red line, we see the patients who undergo active surveillance. But that group also includes the patients who develop a local regional recurrence during active surveillance and need to undergo esophageectomy. So that group also includes the 83 patients who underwent surgery in the end. Still, we see that at 6 and 9 months after completion of neoadjuvant chemoradiotherapy, patients have a clinically relevant and statistically significant improved health-related quality of life on the short term. Therefore, I would like to conclude that patients undergoing active surveillance had non-inferior overall survival at 2 years, that patients with a local regional regrowth during active surveillance could be operated safely and timely, not jeopardizing overall survival, and that active surveillance results in improved short-term health-related quality of life. And of course, there are some points of discussion. We think that one of those points is the rate of distant metastasis. So although not statistically significantly different, we see a 9% difference in advantage of the standard surgery group. So 34% for the standard surgery group and 43% for the active surveillance group, which is numerically higher. So it could be that if we wait a longer time, that it also reaches a statistical significant difference. If this is the case, then we have to see what it does on the overall survival and how that impacts that aspect of the study. But we will have to see with the longer follow-up, and also we have to note that the disease-free survival curves decrease or at least widen from each other after 24 months. So it could be that after a longer follow-up, the disease-free survival also becomes worse for active surveillance. But this needs to be checked in an extended follow-up. And until then, we believe that shared decision-making should be used to discuss active surveillance and discuss the results of the current trial with patients to come to a good treatment alternative. Shortly, that was what I would like to tell you about the SANO trial. We did it with a large group, 12 hospitals in the Netherlands, with a lot of collaborators and physicians who all included patients. So great thanks to the whole group. And I would be happy to answer any questions if there are any questions.
Very many thanks. That was a fantastic presentation. Congratulations to a huge achievement, randomized phase 3 trial in a very innovative space. Please again put your questions in the chat. Let me start with them. I was in particular surprised by the rather high number of patients who were developing a local regrowth in the active surveillance arm, 96 and 83 receiving surgery. If one compares that to rectal carcinoma, where we also follow an active surveillance strategy, what is your explanation about these high rates of regrowth? Have you identified any patient cohorts which are at higher risk for regrowth based on tumor characteristics? Can you elaborate on this?
Yeah, that's a very good question, because it would be very good to know on beforehand what patients are at risk to developing a local regional recurrence. You could also perhaps adjust your follow-up scheme for different patient groups or something. So that would be very, very good to have. Unfortunately, we have not yet looked into that in detail, so I can't really give you hard data on this, but we know that from the pre-SANO trial, which we performed prior to the SANO trial, that there were no clear characteristics that were predictive for missing residual tumors, because that's actually the question, I think. Because if you have a local regional recurrence after reaching a clinical complete response, then obviously our clinical response evaluations at 6 and 12 weeks were not able to detect the residual tumor. So that's a very interesting question, and I think we just have to keep on putting effort in increasing the accuracy of the response evaluations to decrease the rate of local regional recurrence during active surveillance.
Now, the immediate question is about the safety of the salvage, or call it salvage, surgical procedure. You mentioned that in the overall cohort, there was no difference in complications, grade 5 toxicities. You also mentioned that the complications in general, both in the primary setting and in the salvage setting, were rather high. But you as a surgeon, I mean, do you notice a difference? And is there particular patients, for example, with a longer waiting time or a longer interval between the radiochemo where you still notice a difference where there are more complications? Or is that kind of really not observed at all?
No, we haven't observed it in terms of standardized forms or something. So that's not what we analyze standardly, but only from surgeons within our hospital and also who performed the trial. We have not heard of any that it was harder to operate on patients who were postponed later. So it does not seem that waiting longer results in a harder operation or a more difficult operation. You could argument that perhaps you have more fibrous tissue or something if you wait longer, and that results in a more difficult operation, but that's not what we hear from the surgeons within the SANO trial actually, and we also don't see it back in the numbers.
What is very important, we discussed it before the webinar. I mean, these patients are only in brackets being treated with a cross regimen, so the radiation dose is 41 gray. So it is not a definitive schedule where we know that in the salvage situation and the complication rates are higher.
Exactly. That is really good to recognize that it's really different using a neoadjuvant chemoradiotherapy scheme or a definitive chemoradiotherapy scheme.
There's a couple of questions. Robert Jäger is asking a very obvious question. Are there any differences between squamous and adenocarcinoma?
Well, yes, there are. Of course, in terms of, perhaps you will know, of course, in terms of the rate of the pathologically complete response, which is higher for the squamous cell carcinoma, obviously. We also see that the survival differences, if we see we did subgroup analysis, of course, then you see that the overall survival differences comes mainly from the patients having adenocarcinoma. But we also see, because we were quite skeptical in the beginning whether patients with adenocarcinoma also retain their clinical complete response, or maybe all patients with an adenocarcinoma in the end need to undergo esophagectomy, but that does not seem to be the case, because we also see that like 2/3 of the patients who have a persistent clinical complete response still have an adenocarcinoma. So we often get the comment that it's quite strange that we include also the patients with an adenocarcinoma, but we see that also patients with adenocarcinoma benefit from active surveillance within our trial. And it is reality that in the Western world, the majority of patients have an adenocarcinoma. So also those patients benefit from active surveillance.
Important question from a methodological perspective from Thomas Faustino. The surveillance is the same in both groups.
Well, the active surveillance, of course, is more intense, because patients, the surveillance in terms of defining a clinical complete response is exactly the same. So all patients underwent a response evaluation at 6 and at 12 weeks. And afterwards, they were randomized in active surveillance or standard surgery. And if you underwent standard surgery, then you did not undergo surveillance in terms of endoscopy or endosonography or PET-CTs. You only underwent the regular follow-up, and patients undergoing active surveillance have an intensive follow-up with endoscopy, endosonography, and PET-CTs, of course. So the defining of clinical complete response is exactly the same between both groups, but afterwards, of course, the follow-up is different.
Another question by Jay. So what is the benefit, or what are ways to either increase the proportion of patients having a complete clinical response and thereby being offered an active surveillance, or what is the value of intensification to potentially decrease the number of patients developing a regrowth or a persistent disease? So what are your strategies you're following in future clinical trials?
Yeah, that's a good question, of course. Yeah, the main goal is, of course, to have as much people, a lot of people who have an organ preserving method, that would be great. And to have less local regional recurrence in the future, perhaps by increasing the pathologically complete response rate. So we are performing the SANO 3 trial right now, where we add immunotherapy to neoadjuvant chemoradiotherapy. So we administer nivolumab in the post-neoadjuvant chemoradiotherapy setting, hopefully decreasing local regional recurrence rates. And we are also treating patients with like a TNT scheme, total neoadjuvant therapy scheme, combining both cross and flood therapies, and hopefully thereby increasing pathologically complete response rates for those patients.
Another question in the chat is a potential comparison of the disease-free survival in the adenocarcinoma cohort between the ESOPAC trial and the SANO trial. I think this is not really possible because you only enroll patients which are being in complete clinical response, so that would not be a one-by-one comparison.
No, I think that's the correct answer, and also the follow-up and also the response evaluations are very different, and well, obviously it are two different countries, so trial to trial comparison is often sometimes hard.
Then there's another question by Matthias Guckenberger.
Sorry, one moment. Sorry. Sorry about that.
We're all being at the hospital. We are all at work, and no one kind of cares what we're doing behind closed doors.
Sorry about that.
So Matthias Guckenberger is asking about ways of radiotherapy intensification. Rectal cancer, we have the experience of the contact brachytherapy. So are there any kind of interventions, plans to increase the radiotherapy dose, either by EBRT or by using brachytherapy?
I'm not a radiotherapist, but I don't believe that those two techniques are being used in esophageal cancer right now. We do use only in the experimental setting the proton therapy. You guys know a lot more about it than I do, but that's the only thing I know that where different radiotherapy techniques are being used.
Another question, I mean, for the overall survival, the curves looked very similar. For the disease-free, you also mentioned that it appears that with longer follow-up, there might be an increased risk of failure in the surveillance arm. Your clinical trial does allow long-term follow-up analysis, I guess. So
yes.
We expect kind of a 5-year results in the upcoming years.
For sure, because in June 26, so it's a little bit more than a year. Then the minimal follow-up is 5 years. So we will analyze those results thoroughly, and then we will get a definitive answer on the overall survival and also on the disease-free survival and the distant metastasis. So we
that is excellent.
Results.
That makes my planning for the virtual grand rounds in the Q2 or Q3 26 easy, so I have a booking already. Excellent.
Perfect. I would be happy to present the long-term result then.
I don't see any further question in the chat. Here's one. Has the results of the ESOPAC trial and of the SANO trial kind of changed your practice? So as adenocarcinoma, what is your strategy in the neoadjuvant setting based on the interpretation and comparison of ESOPAC and SANO trial?
Yeah, so the ESOPAC was published very recently, actually. So the inclusion period of the SANO trial was already completed very long before the ESOPAC was published. So it did not.
In your daily practice, in today's clinical practice.
Today's clinical practice, we have there is some impact of the ESOPAC trial because we treat, but actually we did that already for quite a long time. We treat patients with an adenocarcinoma who are node positive, mostly N2 actually. We treat them with flood chemotherapy instead of chemoradiotherapy. And also patients who have a very long tumor where the radiation field is a bit too big. Sometimes we treat them with chemotherapy, but mostly nodal positive patients with, we believe, high risk of distant metastasis, we treat them with flood chemotherapy instead of cross.
So mostly high-risk patients, N2 disease, and very large tumors where you might also assume that the toxicity of radiochemo becomes higher.
Exactly. Yeah.
Okay. I don't see any further question in the chat. Berend, many, many thanks already. It was excellent having you with us, and congratulations again. And
Thank you so much, and thank you for the invitation.
let me share my screen again to illustrate. Oh, that is the wrong slide. Our next virtual grand rounds, I'm very happy to announce for June the 4th, again a Wednesday, as you would expect, Marasha Reingold, and she will present non-operative management by using SBLT for PANC-F for resectable pancreatic carcinoma, a single-arm phase 2 trial, which has just been published in the JAMA Oncology. Again, many thanks for joining. It was fascinating having this exchange. I'm wishing you a good evening and see you soon in 4 weeks. Bye, everyone. Many thanks, Berend.